So this was about the coronary artery disease, what we have studied. So let us now study the very important thing, how should we approach when a patient of a coronary artery disease comes to you. Okay, so just I wanted to show you a beautiful image and diagram. So we have already studied. Let us just go through it once quickly. Whether when a patient comes to you and he is complaining of three important acute rest angina, okay, please fulfill the criteria those of definition, that is rest angina more than 20 minutes, rest angina more than 20 minutes, crescendo in the nature, and third, new onset and new variety. If it is present, then please label it as an acute coronary syndrome. So you should admit all the patients who are having acute coronary syndrome. How you will diagnose acute coronary syndrome clinically? Rest angina should be more than 20 minutes. The angina should be crescendo in the nature. It should be crescendo in the nature. It should be new onset and of new variety it should be. Okay. So if this is there, you should admit such patients. The second step is that after admitting, within 5 minutes, ideally within 5 minutes, you should do an ECG in your hospital. What is the ECG will show? If the ECG is showing ST segment elevation, then you have to label it as ST segment elevation myocardial infarction. However, if the ECG shows ST abnormalities or certain times normal ECG also you may see. I repeat, the ECGs may be normal or it is not elevated. Anything which is elevated, we have labeled it as an ST segment elevation myocardial infarction and we have started the treatment. However, if the ST elevations are not present, then you have to do cardiac biomarkers as a next step. So what if you do an ECG and you do not show any STT changes, but patient is complaining of chest pain, angina at the rest, which is worsening, sweating and terrific. So you did an ECG within 5 minutes in your hospital. However, the ECG is not showing any ST elevation. Please do not label it as normal and discharge the patient. Mind me, I have seen a lot of patients coming back with sudden cardiac arrest and there has been a lot of issues regarding the same. So such patients to undergo cardiac enzymes, that is HS troponin I or C has to be done. See whether they are rising or are they normal. If they are rising, then it is non-ST segment elevation myocardial infarction. If it is normal, still admit the patient and treat as an unstable angina. So this is a very important thing in the management of the flow chart. So you should have the stepwise approach. Chest pain, see for acute coronary syndrome if it is present. Then use whether these ECGs are showing any ST elevations or not. If it is showing ST elevation, it is known as ST elevation myocardial infarction. If the STs are normal or it is not changes and troponin level has to see. If troponin levels are rising trends, it is called as a non-ST segment elevation myocardial infarction. If troponins are normal, it is labeled as an unstable angina. So this is a very important concept that one should understand it. Now let us study the management part of the treatment of acute coronary syndrome. Please pay attention. It's a very, very important topic and important concept. So management of acute coronary syndrome. Okay, acute coronary syndrome, we do have two parts. If the blockage is between 70 to 95%, that is subtotal occlusion, we label it as an non-ST segment elevation acute coronary syndrome, which is either unstable angina or non-ST segment elevation myocardial infarction. We have just now studied in detail about this. However, if your ECG is showing ST elevations and the blockage is more than equal to 95%, almost occluding artery, you have to label it as ST segment elevation myocardial infarction. Okay, label ST segment elevation myocardial infarction. So let us study first what is the treatment of non-ST segment elevation acute coronary syndrome, and then we will study the ST segment elevation myocardial infarction treatment. As soon as the patient gets admitted with an unstable angina or non-ST segment elevation myocardial infarction, the foremost thing you have to do is no doubt about that, is the patient should be loading dose of aspirin plus clopidogrel or ticagrelor, not prasugrel, and plus statins has to be given urgently. Whether it is any acute coronary syndrome should receive this urgently. 3 drugs: aspirin, clopidogrel or ticagrelor, that is second antiplatelet agents, but not prasugrel. Remember never to load with the prasugrel in a patient whose coronary arteries are not yet defined, and the statins has to be given. This loading dose has to be given. Once the loading dose is given, the second step is that the drug of choice for such patients is heparin, anticoagulation. Heparin anticoagulation is the drug of choice for such patients. The best anti-heparin drug of choice is fonda. Heparin is either fondaparinux or low molecular weight heparin. I'll say the drug of choice, please kindly correct. The drug of choice is anticoagulation. Among this, fondaparinux is better than low molecular weight heparin, better than unfractionated heparin. So these are the sequence you have to give the patient immediately, and within 3 hours to 24 hours. Okay, within 3 hours to 24 hours of developing this acute coronary syndrome of non-ST segment elevation, you have to take the patient's early PCI, that is angiography and SOS angioplasty. Okay, so this is what you have to do. I repeat once again, friends, for the management of the non-ST segment elevation myocardial infarction acute coronary syndrome. So this is what is unstable non-ST segment elevation. The loading dose of aspirin plus clopidogrel plus ticagrelor has to be given for any acute coronary syndrome because it is an emergency drug along with the statins. Remember, clopidogrel or ticagrelor has to be given. Never give prasugrel. This is very important to take note. And followed by that, the drug of choice is parenterally you need to give fondaparinux or low molecular weight heparin or unfractionated heparin. Whatever among this is the best, you have to prefer that one. And then after 3 to 24 hours, that early PCI, angiography or angioplasty has to be planned accordingly. Angiography and angioplasty has to be planned accordingly. At the end of this lecture, I'll show you how are the angioplasties performed, how are the blockages are being displaced of the atherosclerotic plaque and how the stents are placed. I'll show the video of that also, friends. But this is what very important to understand the acute coronary syndrome management. Is that so clear, friends, about the management of a non-ST segment elevation acute coronary syndrome is unstable angina non-ST segment elevation? So go into the stepwise. Now let us come to the ST segment elevation myocardial infarction. So this is a very, very interesting topic to be studied. ST segment elevation myocardial infarction, this is to be studied. So how we manage this ST segment elevation myocardial infarction? Let me make it very clear first. Suppose suppose a patient has come to you with ST segment elevation myocardial infarction. So your chest pain patient has come to you. You have admitted the patient. You have done the ECG within 5 minutes ideally from your hospital door to the ECG time should be 5 minutes. Okay, 5 minutes within the ECG has to be done. Once ECG confirms that it is ST segment elevation myocardial infarction, if it is confirmed that it is ST segment elevation myocardial infarction, okay, so you have to start the treatment. You have to start the treatment. Now the treatment options what ST segment elevation myocardial infarction is: one is primary PCI, that is primary angioplasty. It is also known as PAMI. That is primary angioplasty in myocardial infarction. Primary angioplasty in myocardial infarction. Okay, so you have got one primary PCR angioplasty, primary angioplasty has to be done. Or another what option you have got is a thrombolysis by giving IV drugs like thrombolytic agents. So primary angioplasty and thrombolytic agents, these are the two options you will have. I'll go into details of it, friends, but first let us discuss how the timing and what is the treatment in both these options, what you can give the patients the best. If the patient has come to you within first 0 to 2 hours of chest pain, if 0 to 2 hours, if the patient has come to you, okay, if the patient has come to you within 0 to 2 hours, that is known as golden period, that is known as golden period, okay, that is known as golden period. If it comes within first 2 hours of the chest pain, मतलब पेशेंट को छाती में दुखने लग गया है, आप लोगों ने एक्यूट कॉर्नरी सिंड्रोम किया है, आते ही डायग्नोसिस कर दिया और 2 घंटे ही हुआ है, 2 घंटे के अंदर अंदर हो गया है, तो ऐसे पेशेंट्स को रिमेंबर thrombolysis and primary PCI is the best option in them. Of course, thrombolysis will be better also if you given the time bolus dosage, but both are almost equivalent in the management. मतलब आप इंजेक्शन देकर भी उसको ट्रीट कर सकते हैं और उसकी एंजियोप्लास्टी भी कर सकते हैं. एंजियोप्लास्टी तभी कर सकते हैं जबकि वो 90 मिनट्स के अंदर आप कर सकते हैं. इतनी कैपेबिलिटी आपके पास होनी चाहिए. यू शुड हैव दैट कैपेबिलिटी ऑफ डॉक्टर्स, advance all the stuff, that within 90 minutes you can do an angioplasty, then only take. But I'll suggest you thrombolysis, if the option is there, you should go ahead and get it done also. The both options are equal. So first 2 hours, that is golden period, thrombolysis is also almost equivalent to the primary angioplasty. Okay, primary angioplasty. However, if patient comes between anything between more than 2 hours, anything he comes between more than 2 hours, second point, more than 2 hours to 12 hours if he come of the chest pain, मतलब chest pain start होने के बाद to more than 12 hours to more than 2 hours to 12 hours if it comes between them, in that condition, of course, primary PCI मतलब primary angioplasty जो हमने पढ़ा है, the primary PCI is always better than the thrombolysis, is always better than the thrombolysis. The best example recently we had Mr. Kapil Dev. We know that he had a myocardial infarction recently and he had to undergo an emergently angioplasty. So the time period, stipulated time was between 2 hours to 12 hours, and that's why the angioplasty was performed. And since all the doctor teams were available and it could have been performed within 90 minutes, so primary angioplasty was the best option for that patients. Number 3, if the patient comes more than 12 hours to 48 hours, okay, 12 hours to 48 hours, if the patient comes between 12 hours to 48 hours of after onset of chest pain, मतलब chest pain start होने के 12 से 48 hours के बीच में अगर आया, which is the most common scenario we do see in Indian populations. So in that, friends, remember, only option in these patients are thrombolysis. The only option in this is the friends is primary PCI, because thrombolysis is contraindicated. Thrombolysis is contraindicated. Okay, भले ही 90 मिनट्स में होगी नहीं एंजियोप्लास्टी, तब भी आफ्टर 12 hours primary angioplasty is the only option one should have. Thrombolysis is contraindicated after the more than 12 hours. Kindly remember this, very important MCQ. Thrombolytic agents cannot be given. Of course, in absolute contraindications, thrombolytic agents cannot be given, but thrombolysis is also contraindicated if it is more than 12 hours. Lastly, if the patient comes more than 48 hours, ऐसे भी कुछ patients है, they will come after 48 hours, very commonly again seen in Indian scenario. So you have to, nothing you can do, you have to first check the viability of myocardium, whether it is dead or viable. Check the viability of myocardium. How will you check the myocardium viability? Either by the PET scan, very important, by the PET scan, or by cardiac MRI. Okay, so you have to check whether the myocardium is viable or not. because more than 48 hours had happened after the occlusion. We are studying the STEMI where the blockage is almost more than equal to 95% to 100% the block is there. So completely totally occluded artery is there. If totally occluded artery is present, more than 48 hours if it is there, first check the viability. Bhai jaan bachiye ke kuch nahi. Only if it is viable, only if viable, only if viable, only if viable, then perform primary angioplasty. That is, angioplasty has to be done. Otherwise, if it is not viable, if viable, yes, if viable, no, then medical management using anticoagulation. Anticoagulation. Okay, anticoagulation. Of course, the patient will receive the aspirin, clopidogrel or ticagrelor and statins. This has to receive plus anticoagulation. So this is a very, very important thing. You should remember. I'll repeat again. If more than 48 hours have happened and the patient has come to you for performing, then you have to check the viability study has to be done, whether that myocardium is viable or not. And how I will check this viability? Either you can perform cardiac MRI, or the best one among these both is the PET scan. So if the facilities are available, you can go ahead and do the PET scan, and then PET scan, see whether they are viable or not. If it is viable, then you can go ahead and do the angioplasty. If it is not viable, only medical management has to be done with aspirin, with the statins, and either the second antiplatelet agent in the form of clopidogrel or ticagrelor. Okay, in both these, ticagrelor is better than the clopidogrel. I repeat again, ticagrelor is better than clopidogrel because clopidogrel has got a resistance. Okay, so this you can give about. So this is about the management part of the ST segment elevation myocardial infarction. Again, I repeat friends, so very important, whenever a patient comes to you with the chest pain, admit the patient, and within from 5 minutes from the door to the, you should get the ECG done within 5 minutes. The ECG has to be performed within 5 minutes. After the ECG, confirm whether it is ST segment elevations are there or not. If ST elevations are there, you have got two options, either thrombolysis or primary angioplasty, or angioplasty can be performed. Thrombolysis or angioplasty can be performed. If you have to see, if it is between 0 to 2 hours of chest pain is present, within 2 hours the patient has come to you, it is a golden period friends. Remember, this is known as golden hour or golden period. If it comes, thrombolysis or almost equivalent, and then primary angioplasty, both are equivalent. Whatever the facilities, you can go ahead. Thrombolysis is always a better option because of ease, no requirement of the cath lab. Of course, there is a risk of bleeding tendencies, but yes, thrombolysis is almost equivalent to primary angioplasty. However, the patient comes more than 2 hours to 12 hours in between them. Of course, in them, primary angioplasty is better than thrombolysis because angioplasty, but provided that it is done in a stipulated time, that is within 90 minutes from door to the performing, opening the artery and putting the stent, it should be done at earliest as possible. So it is primary angioplasty is to be done. It is preferred over the thrombolysis. After 12 hours, thrombolysis is contraindicated. It is better avoided into them. After 48 hours, it is to be avoided into them. That is what is very important to remember. And then later on, thrombolysis contraindicated after 48 hours. Please check the viability of that myocardium. If it is only viable, only then perform by the PET scan or a cardiac MRI. Confirm it. If it is viable, only if viable, yes. If the viability is yes, then perform the angioplasty because thrombolysis cannot be performed after the 12 hours. And if it is less than, if it is not viable, no viable, then medical management with the same aspirin, clopidogrel, ticagrelor, statins and anticoagulation has to be given about that. So this is it. Very important management of the ST segment elevation myocardial infarction in the coronary artery disease. So it's a very important concept. I hope so you have understood this various important concept of the this thing. Let us come to the very important part now, that is a contraindication for thrombolysis. Okay, so we are going to study the contraindication for the thrombolysis. So very important this part. Number 1, what are the contraindication for the thrombolysis? Yes, very important. First contraindication to thrombolysis is number 1, cardiogenic shock. Okay, very important. That means systolic blood pressure is less than 90 mm of Hg with any one end organ damage. So if you have got cardiogenic shock with myocardial infarction, ST segment myocardial infarction, okay, remember one thing friends, thrombolysis cannot be used in non-ST segment elevation myocardial infarction. Please make a note of it. I have seen a lot of students making such mistake. Thrombolysis is only and only used in ST segment elevation myocardial infarction. It is no more used, not used in unstable or non-ST segment elevation infarction. So if you have come a patient with ST segment elevation myocardial infarction with cardiogenic shock, that means what is definition of cardiogenic shock? Less than 90 systolic with any one end organ damage. So in such patients, thrombolysis is contraindicated. So what will be the treatment in cardiogenic shock with myocardial infarction? Immediate treatment and definitive treatment. The immediate treatment and definitive treatment. I repeat again, what are the treatment of cardiogenic shock with myocardial infarction? So for example, a patient has come with a myocardial infarction and his systolic blood pressure is less than 90 with any one end organ damage. If you see, so immediate treatment is what? You should put an IABP machine. Okay, IABP machine. What is IABP machine? Let me make it very clear. It is intra-aortic balloon counter pulsation. Intra-aortic balloon counter pulsation techniques. It is one of the machines which will increase the diastolic pressure, diastolic blood pressure. How it will help? Can anyone tell me? This machine increases the diastolic blood pressure. Okay, it does not increases the systolic blood pressure. Now you say, sir, you have to tell about that the definition of the blood cardiogenic shock is systolic blood pressure less than 90 mm of Hg with any one end organ damage should be present. So and then by using the intra-aortic balloon counter pulsation machine, you are increasing the diastolic blood pressure. How is that going to help? Friends, remember I said you the concept of transcoronary perfusion pressure. That is the difference, the pressure at which the coronary arteries blood flow is maintained or the coronary artery blood supply is maintained. So that is the reason friends, how it is been defined. It is the difference between the diastolic blood pressure of the aorta and the diastolic pressure of the left ventricle filling pressure. So if you increase the diastolic pressure of the aorta, obviously you will increase the coronary perfusion pressure and thus the coronary artery will perfuse more and our purpose would be solved. So immediately is what you need to put the IABP machine and increase the coronary perfusion, and the definitive treatment is, since thrombolysis is contraindicated, primary PCI, that is primary coronary intervention or primary coronary angioplasty. So it's known as primary coronary angioplasty. So this is the treatment of choice for definitive treatment in case of cardiogenic shock. Is that so clear friends? We are studying, remember, cardiogenic shock is the most common complication. It's the most common complication of acute coronary syndromes, particularly ST segment elevation myocardial infarction. Please make a note of this friends. It is the most commonest complication. That is what you are supposed to know, is the most commonest complication. So the most common complication of acute coronary syndrome is the friends cardiogenic shock. Okay, so cardiogenic shock by definition, anything systolic blood pressure less than 90 mm of Hg with any one end organ damage if it is present. So such patients to be labeled as in cardiogenic shock with myocardial infarction, and the immediate treatment is choices for them is putting an IABP machine, that is intra-aortic balloon counter pulsation, and the definitive treatment is primary PCI, that is primary coronary angioplasty. So this is a very, very important thing one should label. The second important contraindication for thrombolysis is very important, is a ST segment elevation myocardial infarction with cardiogenic shock, with with heart failure, again here the treatment of choice, of course, no doubt about that. Immediate treatment is the, of course, is the furosemide can be given, probably that if the systolic blood pressure is more than 90 systolic, you can give furosemide. And definitive treatment is of course primary PCI. So ST segment elevation with heart failure, the immediate treatment, again it is contraindication for thrombolysis. Better to avoid thrombolysis because it can cause alveolar hemorrhage, pulmonary hemorrhage and pulmonary edema. Okay, so this is what is one of two very important to remember: ST segment elevation myocardial infarction with heart failure. Remember, in ST elevation myocardial infarction, one point I wanted to focus is that there was something we prognosticate by something known as Phillips classification. What is Phillips classification for ST segment elevation myocardial infarction? It is a stage class 1, means no symptoms to the patients. Okay, no symptoms to the patient. Class 2 is fine basal Krebs. Class 3, Phillips classification, class 3 means you have got frank pulmonary edema, and class 4 is cardiogenic shock. I repeat again, Phillips classification is for prognosis of ST segment elevation myocardial infarction patients. So what is that classification? Class 1 means patient has no symptoms, no breathlessness, nothing, no symptoms of heart failure. Class 2 is, if you keep the stethoscope basally here and here, you will hear small Krebs will be present. However, at the apex, if you kept the stethoscope, you won't hear any sort of Krebs. That means it is early failure. Patient has not developed yet frank pulmonary edema. Class 3 means there is extensive bilateral Krebs till the apex. Extensive bilateral Krebs till the apex is nothing other than known as pulmonary edema. So if patient develops pulmonary edema, that means into frank heart failure patients. Again, it is related to it is contraindication for thrombolysis, remember. Okay, and class 4 is the cardiogenic shock. So always remember this classification, very important. Please keep a note of this. It is given very nicely in the Harrison and it has to be always kept because it is one of them which is asked very frequently, friends. Okay, so this is what is the ST segment elevation with heart failure. The immediate treatment is the furosemide if systolic blood pressure is more than 90, and definite treatment is primary PCI has to be given. Next, third contraindication is ST segment elevation myocardial infarction with unstable arrhythmias. The word unstable means systolic blood pressure is less than 90. Remember one thing in life, friends. Okay, whether you understand any arrhythmia or not, any arrhythmia is you are understanding whatever it is, atrial fibrillation, atrial tachycardia, or it is ventricular arrhythmia, ventricular tachycardia, ventricular fibrillation. If patients develop that, okay, and see, first thing is check the pulse and the BP of the patient. If the BP is less than 90 systolic and pulse is not very good, it's feeble, the only treatment of choice is shock has to be given to the patient urgently, because that is the immediate and the only treatment for less than 90 systolic. So immediate treatment is DC shock, that is direct current cardioversion. Okay, 200 joules has to be given when it is ventricular arrhythmia and 100 joules you can give when it is atrial arrhythmias. Okay, for ventricular more muscle mass is there, so for ventricular arrhythmia 200 joules, for atrial arrhythmias you have to give 100 joules. When we will discuss the ECGs and the arrhythmias part, at that time we will definitely discuss about this. So the immediate treatment is the DC shock, direct cardioversion more than 200 joules, and 200 joules for ventricular arrhythmia and 100 joules for the atrial arrhythmia. So this is a very, very important concept that one should make a note about that. Is that so clear, friends, about? And of course, the definitive treatment is the primary PCI. Primary PCI is the definitive treatment to this. So primary PCI is the definitive treatment to this. Is this clear? So friends, so very important, definitive treatment primary PCI is to be done according to this. Is that so clear, friends? So these are the contraindication to the thrombolysis. Other contraindication to the thrombolysis, I'll just enlist it. It's a very important thing. That list is very important. So what is the other list? Contraindication to the thrombolysis is yes, cerebrovascular hemorrhage. Anytime if you have got a bleed into the brain, it is contraindication for thrombolysis. Very important to know. Okay, non-hemorrhagic stroke, that is ischemic stroke. If it is ischemic stroke is present, so you have to, ischemic stroke is present within past 1 year, you have to consider for this as an important within past 1 year. The third important condition is the any cerebrovascular accident within past 1 year, any road traffic accident or surgery is done in the brain, it is again contraindication for, absolute contraindication for thrombolysis. Very important to note, friends, very important to note. Okay, next is aortic dissection and aortic aneurysm. Again, this is an absolute contraindication. If a patient is having aortic dissection or aortic aneurysm, if the patient is got, it is a contraindication for the thrombolysis. Next, any active internal or external bleed, any active internal or external bleed, which also includes the menses bleeding. It also includes the menses bleeding. Any active internal or external bleed, which also includes the the menses bleeding. So this has been any internal or external bleeding in the form of bleeding excluding the menstrual bleeding. Okay, excluding the menstrual bleeding. So menstrual bleeding is not absolute contraindication for thrombolysis. This is what one should make a note about that. Okay, and lastly, the seventh one, which is very important, is any intracranial malignancy. IC malignancy, any intracranial tumor or malignancy is again absolute contraindication for thrombolysis. The fourth point which is mentioned here, okay, the fourth point which is mentioned here, friends, it is no more an absolute contraindication, it is only an relative contraindication. That is acute BP of more than 180, 110, you decrease the BP and then thrombolyze, you can give it. So friends, to revise friends, again, contraindication for thrombolysis, you can see the contraindication to the thrombolysis will be is contraindication for thrombolysis therapy. What are this? Number one is the cardiogenic shock, that is systolic BP less than 90 with any one of the end organ damage. The immediate treatment is the IABP machine has to be implanted. Okay, it is a temporary machine which increases the diastolic blood pressure, and by increasing the diastolic blood pressure, it increases the coronary perfusion. And definitive treatment is the primary PCI, primary coronary angioplasty is done. Second is the ST segment elevation infarction with the heart failure. If present treatment, immediate treatment is the furosemide if the systolic blood pressure is more than 90, and the definitive treatment is primary PCI. Third is the ST segment elevation with unstable arrhythmia if present. If unstable arrhythmia is present, systolic BP less than 90, if it is a immediate treatment is DC cardiac shock. Direct cardioversion has to be given, either 200 joules or 100 joules is to be given. If it is atrial edema for ventricular, 200 joules, but definite treatment is primary PCI. Apart from this, we have studied any hemorrhage, any cerebro-CVA bleed is again contraindication for the thrombolysis. Fifth, any ischemic bleed if anything there is ischemic bleed is present, again within past 1 year, within past 1 year, as we have told, within past 1 year, it is again contraindication to thrombolysis. Sixth, any cardiovascular accident, if it has happened, it is contraindication for thrombolysis within, of course, within past 1 year. Seventh, aortic dissection or impending rupture of aorta, if it is present, you have to aneurysm, you have to stop. Active bleeding, except menses bleeding, except menses. Any intracranial malignancy, is contraindication to thrombolysis. So this is what you have supposed to know into the thrombolysis part. Okay, so contraindication to the thrombolysis. Lastly, I wanted to show two important things, that is, thrombolysis, what are the thrombolytic agents. So the preferred thrombolytic agents are the third generation thrombolytic agents are the preferred one. The thrombolytic agents, we are coming to the last part of this session, that is the thrombolytic agents. Thrombolytic agents, friends, can be classified as in first generation, they can be second generation, they can be third generation, and this fourth generation still in the pipeline, yet not produced. So what is the this one, the third generation, first generation. Now the preferred in the market are the third generation. I'll tell you why they are preferred. First generation is the classic example, is the streptokinase, friends. The first generation is the classic. First generation ones are the first generation thrombolytic agents. First generation is age-old streptokinase. So we'll study what was the advantage and what are the disadvantage of it. The advantage is that, friends, it is cheap and a good lytic agent. Okay. Disadvantage is, number one, it is causes anaphylaxis, allergic reaction, anaphylaxis, and the most common allergic reaction is the hypotension. So disadvantage is it is allergic reaction it causes, and the most commonest it causes anaphylaxis is the hypotension. Since streptokinase is derived from the organisms, that is the reason, friends, it will have an anaphylaxis associated with it. Okay. So to overcome this, second generation drugs came. The second generation drugs were the Alteplase. Okay. Alteplase, friends. It is Alteplase. It is known as the, friends. Okay. Alteplase. You can see here. It is very nicely shown here. Alteplase, RTPA. So this is what you can use. RTPA is used, friends. Alteplase. But the disadvantage of Alteplase is what? It is more studied in the stroke patients. Costly drug. It is more studied in the stroke lysis. Alteplase, and disadvantage is that it has to be given over 90 minutes continuous infusion. Okay, it has to be given over 90 minutes as a continuous infusion. Okay, disadvantage of Alteplase is it is also known as RTPA. It is Alteplase. No more use nowadays, but in the myocardial infarction, third generation, which is very important, third generation thrombolytic agent, which is must and routinely used, is the number one, Retiplase, and another is TNK TPA, Tenecteplase. I repeat again, friends, the third generation are Retiplase and tenecteplase. Tenecteplase is weight dependent, is 0.53 kg, 0.53 milligrams per kg has to be given as a dose of tenecteplase. The advantages of both this why third generation came into the market because they can be given as a bolus dose. On contrary, the second generation disadvantage was they have to be given as a continuous infusion dose. Okay, while the third generation can be given as a bolus dosage, sir. It can be given as a bolus dosage. Okay, again I repeat, see, the disadvantage of first generation was that it causes anaphylaxis, and that is the reason the second generation came into the market. Okay, it was developed from the Humana recombinant genes things, and that is the reason the anaphylaxis was not seen or least seen. But the disadvantage of second generation was that it has to be given over continuous infusion over the 90 minutes. It has to be given over continuous infusion over the 90 minutes, and that is the reason, friends, it is a second generation. It is are no more used. The third generation came into the market. The advantage, these are the very fibrin specific. The very fibrin specific, that particularly lies the clot exclusively over the fibrin. Okay, and the another thing is that, friends, they can be given in a bolus dosage, which is a very important. It can be given in a bolus dosage. Among this, retiplase is there, that is RPA, what we called as an, it is can be given in 10 units stat followed by 10 units after 30 minutes of first unit. While TNK, tenecteplase, is weight dependent, it is 0.53 milligrams per kg dose is to be given. The advantage of retiplase over tenecteplase is that it is weight independent. Retiplase is weight independent, and that is the reason you can give this. So these are the two important molecules of third generation. These both are into the market, very well studied, very well doing, and they can be used. The biggest disadvantage is the cost. They are very costly drugs, around somewhere 30 to 40,000 rupees drug, and also 30 to 40,000 rupees drug. And also it is the very important thing about the second thing is that it is to be given like an IV drug. IV has to be given, and that is the reason the fourth generation will be coming soon into the market, that is BB10153. BB10153 is going to come, which will be available orally, but still it is into the pipeline. Okay, so friends, we have got thrombolytic agents. The thrombolytic agents will be like first generation, which have streptokinase and urokinase. Second generation is altiplase, we have studied. Third generation is RPA and TNK, tenecteplase. So these are the important various thrombolytic agents that is one should be remembering and knowing into this. Okay, friends, fine. Thank you so much, friends. This was about the coronary artery disease. Of course, there are a lot of important points which we are going to discuss while discussion of the question answers paper, because one to one will correlate with it. There are certain classification which I wanted to discuss much more, but I will discuss as per the questions, whatever are will be given accordingly. Thank you so much.